It's actually, I'm just presenting one case which was actually done in 2016, and there was a regular follow-up for the last 4 years. A 67-year-old politician with a breathlessness and recurrent pulmonary edema in 3 months. Patient had a dyspnea for the last 2 years behind 2016, that is from 2014 onwards. He was diabetic from 2005. Creatinine was varying, report 1.8 to 2.4 with an echo of LV dysfunction with 22% with a mild to moderate MR. This was the angiogram shown. Basically, there is a significant disease from the LMCA bifurcation. You have a diffuse LAD disease. A circumflex is totally occluded. If you look at the ostial circumflex, actually even the proximal circumflex is diseased. The patient had an RCA disease like this. Here, the distal LMCA 20 to 30% or LAD ostial 50%, diffuse distal disease, osteoproximal circumflex 90%, distal OM filling by collaterals, RCA normal, but PDA is occluded from the mid part. Both PD and PLV are diffusely diseased. The patient actually gone to different people and nobody was willing to do anything, and the patient has actually recurrent pulmonary edema and angina. Patient came to me. We used a 7 French ABU. My plan was to open the OM vessel first of all because of the moderate MR. I put the wire crossed. We used a small balloon, dilated the vessel with a 2 into 12 millimeter balloon. I was a little afraid because the vessel is looking very small from the LAD perspective. Finally, we put a 2 into, actually there is a long stent we have put, that is a 2.5 into 38 stent. Then we have significant dilatation, that is actually 2 into 12. We use a 4 into 24 abluminous stent from the LMCA to circumflex. So we put 2 stents, what LMCA to circumflex and distal vessel, we put a stent distally also. Then we decided, because the LAD looks like very, this vessel was not opened up very well. So I used a 4.5 millimeter balloon, dilated, and went up to 20 atmosphere and opened the vessel and finished the case that time. So I was thinking that I will be difficult because even if I open LAD, the diffuse distal disease. Luckily, the patient after 3 months, cardiac function improved to 45% from 25%. So patient wanted to do other blocks and decided to later, but repeat a request. I just did an angiogram and the looking like this. So the stent which I put was okay, but you can see a minimal ISR in the osteoproximal part of the circumflex, but LAD looks very diffuse disease. But I thought actually this time I will open the LAD. I put a wire, just a 1.25 millimeter balloon, then a 2 into 12 millimeter balloon. I was a little afraid because the vessel was looking very small. So I decided to take a 2.25 stent, that is a 40 stent abluminous, but I thought it would be difficult to able to track. But I took a 2 into 12 millimeter balloon at the ostial part of the LAD, that because there is a stent from LMCA to circuit sitting there. I just opened the strut, but I kept a guide liner up to the ostium. You can just wash that, but through the guide liner, I took a 2 point, that actually the second frame you can see, I have taken the stent through the guide liner, the stent is going down. It is a 2.25 into 40 stent. I opened up. So my colleagues told that actually there is a significant disease down also, but we took one more stent, that is a 2.25 into 24 stent, 35 stent, actually 36 stent. You can see the stent is coming down here. In the left-hand frame, the stent is coming through, and through the guide liner, through the other stent, it came down. So there is a 75 millimeter stent is put into the LAD. So this was the result, but there is an ostial LAD disease, which I just left like that. So this was the final result. I left the patient there. So this was the final result. We did a check angio in 2018 with a mild discomfort, TMT not done, cardiac function improved. Patient wanted to see the coronary angiogram. So the ostial LAD, I don't know whether it is disease was increased or not, but the stent is looking perfect. What I did is actually, I did a similar angiogram picture. So we decided to go on medical management. Exactly after 1 year, that is in 2019, upper epigastric discomfort, echo similar finding, we decided to do an imaging on this case. So the first stent put in the circumflex was perfect. The LED LMCA to circumflex stent, there is a minimal disease in the ostial circumflex, and the diffuse LED disease, which is covered by two long stent of abluminous, looking perfect. So what I did is, and I did an I was showing a 3.7 millimeters square is the area in the distal LED, which I put at 2.25, which is wonderful. And the mid LED circumflex area is 7.2. But actually you can see that the ostial part, it is very, proximal part is very tight, which is only 2.8 millimeters square. So when it is 2.8 millimeters square, what actually 4.2 in the ostial part, 2.8 in the mid part. So the proximal circumflex also, there is a real ISR, which is actually the luminal area is 5.6, but there is a luminal loss. So the LMCA stent is actually 9.9. So we decided to do a pre-dilatation, the LED osteoproximal wart with a 2.5 millimeter. I put a stent, which is a tap technique, 3.5 into 28 stent of science expedition with a tap stent with a balloon here, and then a post dilatation with a 3.5 into 12 millimeter balloon, 3.5 L into LED and 4.5 into circumflex, and final kissing balloon and inflation by a 5 millimeter balloon in the LMCA. And the proximal LED post ending is 7.5, ostial LED is 8.2, and we got 11.8 in the LMCA. This was the final result. So this patient actually still today morning, since I was presenting this case, because of the COVID, he was not on follow for the last 6 months. I called him and asked, how is he? He is doing extremely well, and he's walking 45 minutes every day. That is actually 2 years back, this angiogram done. So the refractory angina patient was rejected treatment due to diffuse CAD. Treating most critical disease can give freedom from angina. A regular follow-up is required. This is my case where I used abluminous, 3 long abluminous and 1 LMCA to circumflex a long stent. Patient is doing extremely well, and thanks to abluminous.
Any comments or questions? Should we move forward?
I have a small comment and a question, Dr. Pratap. When we looked at the angiogram in 2019, the circumflex ostium started to restenose. I mean, angiographically did not look anything significant, but over time. So of late, we are increasingly avoiding putting a stent in the circ ostium because of the angulation, the hinge point. The restenosis always occurs, and there are some data suggesting that the restenosis of a circ ostium is very difficult to treat, we all know. So what's your opinion of maybe avoiding a circ ostium stenting and maybe consider DCB, something which we've been doing a lot these days for left main PCI?
No, LMCA, PCI, what I do is always, we usually take a cutting balloon. Now the Wolverine came up, and Wolverine is a wonderful balloon because it can be taken, very trackable balloon. I do a Wolverine in balloon inflation, open the vessel, actually 1:1 ratio with 3.5 or 3, whatever the size is of circosteum. Then I can use a regulating balloon. But actually in this case, what actually happened, already there is a stent there, LMCA to circumflex. Now there is only no other option. But Wolverine, then followed by regulating balloon is my choice in all ISRs, which is coming with the circosteum. And I have done 17 cases, and they are all doing extremely well.
So I think, yeah, even I have a small comment. So Dr. Pratap, it was a wonderful case. I think really you have been patient and did a huge hard work to get the outcome. My only thing is, while he was checked, you know, the LED ostium was not looking very great in 2019, or I mean year back, or once you were having check angios. So maybe at that point also, if FFR or IVUS or imaging was done, perhaps this could have been the story there at that time also, that it's not looking great.
Correct. But I was actually not at all keen on doing anything to the LED because the LED was significantly diseased down. After putting 2 long stent, I don't want to meddle with that LMCA.
I get it. So at times, you know, we do feel that perfection is not the answer. We give the good result and patient is doing better. So, but just a comment that maybe at that time also it was there, but finally it is well managed. Yeah.
I did not do an imaging that time. That is why I could not.